Acute kidney injury is not just a lab abnormality. It can become life-threatening within hours. Potassium rises, and the heart becomes unstable. Fluid builds up, and the lungs begin to fail. Acid accumulates, and the body starts shutting down. If you miss AKI early, the consequences can be fatal. Acute kidney injury is simply a sudden decline in kidney function. In clinical practice, you detect it when creatinine starts rising or urine output begins to fall. Whenever you see a rising creatinine, think of AKI until proven otherwise. Think of the body as a simple flow. Blood reaches the kidney. The kidney processes it. Urine flows out. Every AKI problem happens somewhere along this pathway. When you see a patient, ask where the problem is in this flow. Everything in AKI fits into 3 categories. Prerenal means the problem is before the kidney. Intrinsic means the problem is inside the kidney. Postrenal means the problem is after the kidney, where urine cannot flow out. If you understand this, you can solve most AKI cases easily. In prerenal AKI, the kidney itself is normal. The problem is reduced blood flow. Less blood reaches the kidney, so perfusion is low. The kidney is not damaged. It is simply not receiving enough blood to function. When blood flow is low, the kidney tries to survive. It holds on to water. It holds on to sodium. It concentrates the urine. This is the kidney adapting to maintain function. A young patient comes with severe dehydration. Blood pressure is low and kidney function starts to worsen. The kidney is not damaged. It is simply underperfused. This is prerenal AKI. If prerenal AKI is not corrected, the kidney becomes damaged. This is acute tubular necrosis. The tubules are injured and kidney function declines. This is no longer a blood flow problem. This is structural damage. In ATN, the kidney loses control. It can no longer reabsorb properly. Sodium leaks into the urine. Water is not conserved. Potassium rises, fluid builds up, and acid accumulates. This is failure, not adaptation. Muddy brown casts are a classic finding. They represent dead tubular cells and protein-forming granular debris. If you see muddy brown casts, think of acute tubular necrosis until proven otherwise. In glomerulonephritis, the problem is in the filter. The glomerulus becomes inflamed. Blood leaks into the urine. The urine becomes dark or red. Whenever you see blood in urine, consider glomerulonephritis. Interstitial nephritis usually occurs after starting a new medication. It is an immune reaction inside the kidney. This causes inflammation and kidney dysfunction. Patients may develop fever, rash, and worsening renal function. Think of this when AKI follows a new drug. In postrenal AKI, urine cannot flow out. There is obstruction in the urinary tract. Pressure builds up and the kidney begins to swell. Common causes include stones, enlarged prostate, and tumors. Always consider obstruction in AKI. An older man presents with difficulty passing urine and a weak stream. His creatinine is rising. This suggests obstruction due to an enlarged prostate. This is a classic example of postrenal AKI. Ultrasound is used to confirm obstruction. It can show dilation of the kidney, known as hydronephrosis. This indicates urine is backing up. In every AKI patient, obstruction must be ruled out. In prerenal AKI, the kidney conserves sodium and concentrates urine. In ATN, the kidney is damaged, sodium leaks out, and urine becomes dilute. Low sodium and concentrated urine suggest prerenal AKI. High sodium and dilute urine suggest ATN. This is based on physiology, not memorization. AKI can be understood through a simple flow. Blood reaches the kidney. The kidney processes it. Urine flows out. If the problem is before the kidney, it is prerenal. If the problem is inside the kidney, it is intrinsic. If the problem is after the kidney, it is postrenal. Always ask where the problem is in the flow.